All right, hi everybody. Thanks for joining. This is the Wilderness Medicine Journal Club hosted by the VTC Wilderness Medicine Fellowship. Today's topic is altitude illnesses. We're going to start with discussion of the guidelines for the WMS guidelines for the altitude illness portion. So Gabriella, whenever you're ready, take it away.
All right, guys, good evening. Assuming it's evening where everybody is, or afternoon. Super stoked to be here. Let me know if I'm talking and you can't hear me and my mouth is moving. We're having some storms here in Florida, so keep me posted if you can't hear anything. I'm gonna show a short video, so if I play it, I think we have plenty of time, so make sure we can get the audio up on that, but just interrupt me because I can't see the chat in presenter mode. So interrupt me if you can't hear it or there's any issues. So other than that, like I said, I'm in Florida. Hope you like my background. Ironic to be talking about not in medicine today, but really stoked. Born and raised in Colorado. So spent a lot of time in the mountains and excited to present this clinical guideline. It's kind of a dense one, a lot of pharmacology in it if you guys have looked at it. So I'm gonna try to boil it down to what I think are the important takeaways for us as future providers and for any of you that are just avid hikers, avid mountaineers. So hopefully I'll do that. Definitely open to questions, and I'll share my email at the end. I'm a first-year student at Kiran C. Patel College of Osteopathic Medicine here in Tampa, Florida. And as a first-year student, we're just now touching on the respiratory and all that. I'm sure you guys remember it fondly. So this is a learning experience for me too. But like I said, I've spent a lot of time in the mountains, was in the military for a while, and have lived in some very high altitude places. So hopefully I can share some clinical pearls with you, and hopefully you guys feel free to jump in if you have experience with this or experience using any of these meds. Definitely would love to hear about it. So hopefully we're going to start with the video. Like I said, I'm going to try to play it. You guys let me know if the audio works. It's like a 1-minute video. So just to get you in the mood.
I'm not you. Okay, now I'm recording. I'll try this out.
So this is Capitol Peak. This is out in Colorado. If anybody's been out there or climbed it, I've climbed it. This is the famous Knife's Edge. A lot of mountains have what they call Knife's Edge, but this is a pretty famous one in Capitol Peak. Few people have died on this one. I have some friends who have died. They were also intoxicated at the time, so not really surprising that they took a big tumble. But if you fall off the sides of this thing, you're essentially falling a minimum of about 300 feet. So this one is no joke. So just want to show you guys this, and then try to imagine doing this if you're experiencing the effects of altitude. If you're not acclimated, it's kind of a death trap. So enjoy. All right, so that is a perfect example of something you don't want to do or let your friends do if they're experiencing altitude intoxication, as we used to call it, altitude illness of any kind, right? Because like I said, it's kind of a death trap. But I hope to also show you that this is not the only example of altitude. When we think of altitude illness, it can happen in a lot of places that are up on the Knife's Edge or at the base camp of Everest, right? So we'll talk about that.
I'm not you.
So here's what we're going to talk about. Like I said, the clinical guideline is dense, but it's pretty good. If you guys haven't looked at it, definitely would encourage you to give it a quick review. And if nothing else, have kind of a cheat sheet of the mountain meds that are incorporated in there so that you kind of know the quick dosage and what to have in your kit if you're out doing this kind of stuff. So I'll talk about AMS and Haste and HAPE. If you don't know what that is, that's okay, because we'll talk about it, and some of the clinical takeaways from the clinical rec itself, and then from my experience climbing mountains. So first off, just a quick refresher on the physiology of it. It talks a little bit about this in the guidelines and why this is relevant to you. So I don't know if anybody's in Colorado. If you are, let me know. Super jealous being here in Tampa. It's great, but I miss the mountains. So this is a topo map of Colorado. You can see the red areas are about 11,000 feet plus. So certainly altitude illness affects a ton of people every year out in Colorado, and I'm sure you guys can imagine that. A lot of medical students go to Nepal for mission trips, except maybe not during COVID, but this is a really popular spot. So here's a topo map of the area around Mount Everest, Kathmandu, and I know in a couple of weeks, Dr. Gardner has set up an awesome talk with some of the providers from out there, so that'll be really interesting. I know they'll have some good expertise, but you can see the altitude here. We switched to meters, and the brown up to the white is anything from about 5,000 meters up to Everest, which is 24,000 something feet. So you can imagine that all the effects we see in a place like Colorado are even more magnified in a place like Nepal, right? And even the base camp of Mount Everest is, I think it's about 18,000 feet. And so you go from 760 millimeters mercury down at sea level where I am. I think the barometric pressure up there is about 360 millimeters of mercury. So your partial pressures of oxygen are just exponentially declining. A lot of medical students, including myself, also have gone to the Andes for mission trips. I also spent a lot of time there in the military doing counter narcotics. And here's another topo map of the Andes Mountains, the Andes Mountain Range. And you can see, again, that reddish dark brown area up to black. That's about 15,000 feet and above. So some high altitudes there. If you're going to be traveling there, you definitely want to keep this stuff in your back pocket. And that's a cat I adopted while I was there. So the cat wasn't having any breathing issues, but we were. So the bottom line, altitude's dangerous. Here's just a little map. You can find all different versions of this, but as you can see, AMS and Haste start to become possible even around 2,000 to 3,000 meters. This is meters. So again, you don't have to be up hiking a 14er in Colorado, or jumping out of an airplane or whatever it is or be at Everest Base Camp to experience these symptoms. There's a lot of cases out there, and maybe some of the case studies will cover it. You can see this stuff in lower mountain ranges. You can see it in the hills. You can see it when people are traveling to Denver or some other places on the high plains. They can still be very much affected by this. And then obviously, as you go up in altitude, when you get up to about Everest level, 7,500 meters plus, 1/3 of climbers are going to have hallucinations. And if you're an Everest buff, you've certainly heard the stories of climbers who got lost in a storm, thought they were descending and were actually ascending very rapidly. And unfortunately, that is how they succumbed. So significant changes starting at the 6,000 meter range and up. Sometimes those changes can be irreversible. And just a quick refresher, not to bore you guys, but altitude and respiration is really all about partial pressures. CO2 really drives respiration. So a lot of people who don't have a lot of background in mountain medicine, wilderness medicine in general, not you guys, but other medical students and even providers don't really understand that oxygen itself declining as you get higher in altitude is not the problem, right? The problem is the partial pressure of oxygen respective to the total barometric pressure decreases significantly, if that makes sense. So that drive to perfuse oxygen into your from your alveoli into your capillaries in your lungs is severely decreased. So there's less pressure pushing that oxygen through to the capillaries. So you become hypoxic. You get that what's called air hunger. If any of you guys have ever heard of that or experienced it, I actually have multiple times, where you start to hyperventilate, you feel like you can't catch your breath, and then you go into, if you don't descend, if you continue to hyperventilate, obviously you're going to go into a hypocapnia state, and then you're going to have sleep apnea at higher altitudes. So we'll talk a little bit about the clinical guidelines, the discussion of sleep recommendations. And so this is a vicious cycle, and if you don't descend rapidly, you're going to have severe problems. Just wanted to throw this in there. It's not in the clinical rec, but Cheyne-Stokes respirations, if you hear about this term, you're really talking about 10,000 feet or above. So that's about Vail Ski Resort, if you need a reference, and above. People are going to experience Cheyne-Stokes respirations generally during sleep. So I'll talk about what the clinical guide says about how to prevent this and then how to treat it. One of the kind of gold standard treatments for this is acetazolamide, and we'll talk a lot about that. But just know, as the barometric pressure falls, altitude increases, the composition of the air remains the same, but again, the partial pressure of oxygen is now decreased, and all the gas pressures are decreased because there's less oxygen. So certainly that when you're sleeping and your body is relaxed, there's even less drive to perfuse oxygen, so that can be problematic. So here's the medical conditions that are covered in the clinical guideline. If you're not familiar with these, I expect probably a lot of you are because you're in this group, but we'll just talk about the progression as it goes in the clinical guidelines. So acute mountain sickness is the first thing you'll see. If it's untreated, if the person does not descend or at least stay at a comfortable altitude until they acclimate, they can progress to HASTE, which is cerebral edema. This is very dangerous. And then also we'll talk about high altitude pulmonary embolism. And you can see some of the symptoms there. The thing is with AMS that makes it very tricky is, and if you're experiencing this, you can explain away pretty much all of these symptoms. So the nausea and vomiting, some people just attribute it to not eating enough on their hikes. The dizziness can just be, some people have said, oh, it's, the sunlight, right? Because at extreme altitudes, it's very bright, especially when there's snow. So it's because of the light reflections making me dizzy. Lightheadedness, again, can be, oh, I'm just dehydrated, right? So you tend to explain these things away until it really becomes a problem. And what you don't want is to not be aware of it or to dismiss it if it's happening in one of your patients or in yourself, and then you progress to cerebral edema, which becomes an emergency situation. And I have seen cerebral edema only a couple times at high altitude, but it's a pretty scary thing for the person and for you. The person basically, they get to this point, they have ataxia, which is a classic sign. You ask them to do like a tandem gait walk, which they're doing like, 1 foot in front of the other along the line, and you'll see them stumble, they'll fall over. You try to talk to them and they're sitting there just kind of looking at you, but nothing's really coming out. So that can be pretty scary. And the problem with that is the person becomes non-ambulatory. So getting them down a big mountain is really going to be a serious issue at that point. And then if they progress to coma, you've really got a situation. HAPE is another one we'll talk about. A lot of people think of the frothy pink sputum as the telltale sign, but if you've gotten to the frothy pink sputum, you have not done your job as a medical provider because, and I'm just looking at a note in the chat, insomnia has been removed from the Lake Louise score. Yeah, so the Lake Louise score, if you guys, I don't have it in these slides, but definitely check out the Lake Louise scoring system for these. Probably have like old information on here. So insomnia has been taken out. I'd be curious to know why that is. I don't know if anybody can answer that, but sleep is definitely an issue because of those Cheyne-Stokes respirations and that. So something to be aware of at least. And then we'll talk about HAPE a little bit more too. Okay, perfect. Someone has Lake Louise 2018 as one of their slides, so you guys can see the criteria there. So if you have no idea what I'm talking about, don't worry, it's coming. So HASTE, like I said, really, really a critical situation if you have HASTE. This is where AMS has progressed because someone's not paying attention. You should have already caught the signs, but the person progresses into altered or lost consciousness and ataxia. Again, a good way to test that is have them do that tandem gait. If they can't do it, you'll know right away, and you'll know that you have an emergency. There's other neuro findings that you can see. This is some imaging that was done by the U.S. Army that shows someone with high altitude induced cerebral edema. And obviously you're having permeability issues, you're going to have cerebral edema. Obviously you're going to start seeing lesions of the corpus callosum, which is one of those things that may potentially be irreversible if you don't medevac this person immediately. There's also some reversible white matter edema, but again, once you get to that phase of loss of consciousness, your patient's in really bad shape. And then HAPE, this one is more common, by far more common, usually because people recognize the signs of this and know kind of what to do. So HAPE, easy way to diagnose this, if you're up in the mountains and if you have your stethoscope, you can listen for crackles or rails on auscultation. Best place to do that is the right middle lobe of the lung. So a good way to find that is just the right axilla. You can listen in there on the person, and if they've had HAPE, if they're progressing with HAPE, you're going to hear some telltale crackles there. They're going to be tachypnic, they're going to be tachycardic. So you know, again, if you have methods to keep track of their heart rate and you're monitoring the respirations, you should see that. Shortness of breath and confusion, again, be careful because you don't want to just explain these things away or say, oh, you know, man up, suck it up. People tell you that, and then next thing you know, you're laying on the ground and you have no idea where you are, and nobody can move you down the mountain. Fluid buildup in the lungs is really the pathology here. So once you have that and you combine that with the air hunger, oxygen hunger, you got a pretty bad situation there. So there's some additional information on it. I won't belabor the point, but I'll send these slides so you guys can have them too. So really quick on methodology, it's the same for all the clinical recs. Basically, WMS assembles an expert panel and they review the current literature and they give recommendations based on the quality of supporting evidence. And what they use specifically for this is the criteria of the American College of Chest Physicians for obvious reasons. You're dealing with respiratory issues. So of course, those criteria would be fitting. And I'll talk about how they rated each of the criteria in just a minute. Okay, so here is kind of the meat and potatoes of the clinical guidelines. So we'll first talk about prevention. So as far as non-pharmacological prevention, here are some of the things that are talked about. So gradual ascent is gold standard. Always people should be making a gradual ascent unless they're highly trained. And even then, even like military special forces guys, they really focus on gradual ascent. And in particular, we're talking about your sleep elevation. So in the clinical guide, they talk about even if you're ascending, you know, several thousand feet in a day, it's really how per night, how high are you ascending to where you're sleeping at. Really maximum, according to the clinical record, should be about 2,000 feet. If you're not well trained, 1,000 feet is kind of a stretch for you, but maximum 2,000 feet. So again, sleeping tent, right? So do your hike during the day as long as you feel okay and you're not having symptoms. But when you come down to sleep at night, you should always be coming down literally to sleep at night. Stage descent and pre-acclimatization, it's kind of a medium grade recommendation in that it's not always possible. So for example, I'll be flying out to Colorado in a few weeks to Vail from Tampa, Florida, 0 feet, to go to a wedding in Vail. So I don't really have the luxury to pre-acclimatize to sit around in Denver for a couple weeks until my EPO goes up and all that, right? But if it's possible, it's definitely helpful. Stage descent, this is another one. Growing up in Colorado, there was a lot of times where we decided, screw it, it's 2 a.m, we have nothing to do, let's go out to Pikes Peak, which is a 14,000 foot mountain, and let's go hike it today. We were acclimated, living in Denver, living outside of Denver, but nonetheless, you really should plan for a stage descent. Now, there's a lot of other anecdotal things, like the coca leaves are very common in the Andes Mountains. You'll see a lot of locals chewing the coca leaves. They say that oxygenates them. You see similar things over in Nepal, in that area, Pakistan. You'll see that stuff too. Not really enough data to say that it works, but a lot of the local areas, they will tell you it's been working for 1,000 years. So use your judgment. If you've ever seen these oxygenated recovery drinks, they're really popular out in Denver. You can find them at any grocery store, insanely overpriced, but people swear by them. Again, there's not really any data to support or reject their utility. I have drank them and it tastes like sparkling water to me. So, I mean, oxygen is in water technically. So I'm not sure what they're selling, but it's in the rec. Use it if you want. It's probably not going to hurt you, but not really a lot of good data there. I think it looks like I missed something in the chat. Oh yeah, the ultrasound findings. Yeah, so HAPE, you're looking for the B lines. Yeah, exactly. And it's always cool if you have portable ultrasound. You know, if you're at a base camp somewhere or whatever, you should have that kind of stuff. So know what to look for, and like I said, know the lung auscultation signs to look for in that too. Easy thing to carry is a stethoscope, which is why I say that should be one of the things in your kit. And we'll talk about at the end kind of what everybody, all of you, can chime in on what I recommend to be packed in your kit if you're doing this kind of work. So again, prevention, this is the pharmacological approach. I'm going to touch on this later, but even in the clinical rec, it talks a lot about assessing individual risk. These recommendations are general recommendations, and obviously anytime you're dealing with pharmacology, there's a million caveats and contraindications, but these are the gold standards, tried and true. For prophylaxis for mountain sickness, acetazolamide is the gold standard. The picture there is 250 milligrams, but for prophylaxis, you're looking at, I think, 125 milligrams every 12 hours is standard. 250 is actually more used for treatment or a person who has a history of altitude of AMS. For prophylaxis, according to the clinical rec, you want to start this 24 hours pre-ascent if possible. Even if you don't, though, it still does have utility as a prophylactic. Dexamethasone is contraindicated. I'm sorry, yeah, it's contraindicated. Again, a lot of mountain medicine folks have different views on this, but according to the clinical rec, you're going to go with acetazolamide for prophylaxis. Dexamethasone has been used in the military. I've actually seen it used in the military administered, but it's not really the standard. And if anybody, again, has any different opinions on that, please chime in. But this is just what the recommendation says. So if you're over 2 days at your peak altitude, so let's say you're hiking to the top of Pikes Peak, and you're at 14,122 feet, and you're going to be there for a couple days and you have no symptoms, you can stop the prophylaxis. You definitely want to stop it on descent. If the person is having symptoms, there's some other considerations that we'll talk about, but you can keep giving the acetazolamide. You want to ensure a gradual ascent also. This is really important. The overall ascent rate, there's a little way to calculate it that's in the clinical guide, but just have a plan, especially if you're hiking or climbing with people who are not acclimated. Maybe you just flew into Salt Lake from sea level or whatever it is. Have a plan for that. Really, the goal ideally would be less than 500 meters per day. I know that this is not realistic. I lived in Colorado for a long time, but that is ideal to prevent symptoms. And then I talked about the sleep recommendation. You want to try to at least sleep one night at intermediate altitude. So whatever your max altitude is, use your clinical judgment, figure out what your intermediate altitude would be. If you're going up to Vail, which is about 10,000 feet, and you just flew into Denver, definitely want to try to spend a hotel night in Denver or, hang out with some friends in Boulder or whatever, because you're going to be hurting if you go up to Vail, from the airport. And I know people who do it and they never feel good. And I was born and raised there. Even when I go back there, I can't go straight up to the mountains, and certainly can't go up to the mountains and drink. That's another thing, just to be aware of. So at least give yourself that one night. If it's not feasible, consider pre-climb days. So basically what that means is get up to your base altitude and try to at least hang out there for a little bit if you can. Really depends on the situation. I put down in the corner the mechanism of action of the drugs, just if you're not familiar with some of these. Acetazolamide is a diuretic, so one of the side effects you will see is people are peeing a lot, so you want to make sure people are staying hydrated. Some people will start to get really concerned about that, like, oh my God, I'm peeing so much and I'm at altitude, am I going to die? Like, people have asked me that. No, you're not. It is a diuretic, so it's to be expected. It's a carbonic anhydrase inhibitor. And then dexamethasone we'll talk about again later. So here's just cut and paste from the clinical rec, just so you guys have it. Like I said, for AMS prevention, 125 milligrams every 12 hours. That's your standard. And then for treatment, 250 every 12 hours. Pediatrics, I won't get into. You can check it out there. And then we'll talk about dexamethasone here in a minute. Acetazolamide, you have to know the pediatric dose if you're hiking with or if you're treating kids. Teenagers, I would say go with the adult dose, especially if someone's actively symptomatic. But with kids, just be careful. Dexamethasone can be used. Like I said, the military does use it. Just know how to use it. And then really what I've seen, and I don't know if you guys have seen differently, with dexamethasone, I've seen it administered intramuscular. I haven't really seen it oral for prevention. So I wouldn't recommend that, but that's just my opinion. There are some inhaled drugs that need more data. Ibuprofen is a common one people ask about because one of the first symptoms of AMS is headache. So ibuprofen can be used, but be careful. I won't get into all the caveats of it, but definitely check the clinical recommendation for that. One thing you definitely don't want to use is acetaminophen. Again, I won't get into all the reasons why and the pharmacology of that, but just remember that acetaminophen, Tylenol, really not recommended per the clinical guidelines, and certainly I agree with that recommendation. But ibuprofen is okay if you know how to use it. Also, some people may have contraindications to acetazolamide and dexamethasone. So for example, some people say they have a sulfa allergy. I would say that you should have epi in your kit. And so if someone's in a critical situation and you have to give them acetazolamide, and they say, oh, I have a sulfa allergy, or I think I have a sulfa allergy, give it, don't risk it, don't delay treatment over it. But that's just me. Now, I talked about individual risk factors. This is really critical to making a determination of how you're going to treat these patients because every person is different. I was born and raised in Denver, and I still get sick. Every time I go out there, I get a headache for days. I drink one light beer, and it's like I'm out, I'm done. So, and then some people, you know, my aunt and uncle live in Miami. They go up to Denver and they drive to Vail the same day and they go skiing. So I don't know. It really depends on the person. The picture I put here, this is my brother, Austin. And this is stolen from his Instagram, but he did give me permission. So he's a semi-professional bouldering climber. So you can see the kind of craziness that he does. And he has severe multiple sclerosis. And he's the kind of guy, he can put on his Converse or his little like rock climbing sandals and he'll go climb a 14er just for fun randomly one day. And he has MS. So you wouldn't think, right? And then you always see the people that are coming from out of town up to the mountains. They're in sandals, they're taking cute Instagram photos, and you know they're going to be high risk if they stay at that altitude. So just depends on the person. You really can't tell by looking at a person, or if a person is from a high altitude area, that doesn't necessarily mean that they're low risk. Okay, so know their risk factors. There's a chart there from the clinical guide that breaks it into low, moderate, and high. Pretty much anyone with a history of AMS, you definitely want to be suspicious. That's where you should really push for the coming back down at night, lowering their sleeping altitude, having those pre-acclimatization days, you know, at Denver or Salt Lake City or wherever it is. That's really important. And again, people who are expert mountaineers can still be high risk. So if you're doing a very rapid ascent, like it says there, less than 7-day ascent of Mount Kilimanjaro, like those people who go and run a marathon on 7 continents in 7 days, they may be professional athletes, but you're still going to consider them high risk if you're using this guideline. I actually was just listening to a podcast. I think it's a WMS podcast. So you guys can find it in the podcast store or whatever it is on Apple. And it was a story of a father. And he was talking about his son, who was a high school competitive athlete. And I think he was a senior in high school, very fit kid, had grown up in the Salt Lake Valley, which if you've ever been out there, it's actually lower altitude than Denver, but grew up out there and definitely acclimated, right, by most people's suspicion. Well, he's born and raised there. He's, you know, a really great athlete. He was being considered for several colleges. So this kid goes on a scouting trip and they go up to Park City, Utah. If anybody's been to Park City, compared to like Vail or something, it's not that high. I think it's only about 8,000 feet. There's a ski resort there, but it's not somewhere you would think that a very well-conditioned teenage boy would have issues. But he goes up with his scout camp and progressively over a few days starts to show some kind of weird symptoms. He's less reactive than usual. And I think it was about 3 nights in, he stops eating. So the boys get back from the hike, they're sitting around their campfire in Park City or outside of Park City, and they say, hey man, come eat some food, and he doesn't eat. Now, if you've been in the mountains hanging out with your friends, if someone doesn't want to eat, probably don't think anything of it. You're like, okay, he's tired, we've hiked all day, I get it. But this is one of those times where you don't want to explain away or justify people's symptoms. As a medical person, that should be a big indicator to you. We talked about anorexia as being one of the symptoms, but if you see someone stop eating, that is a good indicator. They might be telling you, well, I feel nauseous, I don't want to eat anything, or I just don't feel good, I don't think I can hold it down. That may be dehydration, it may be they're just nauseous from something else, but it could, and there's a good chance that it is, be an early sign of AMS. So something to be aware of. So this kid stops eating, they go for a hike the next day, he comes back, he's worn out, he naps for several hours, which for a high school athlete, kind of weird, right? You wouldn't expect that. And then, you know, same thing that night, he barely eats. The scout leaders kind of have to force him to eat. And the next day they go out and he says, I can't do it. I'm going to stay here and nap. I just don't feel good. So the scout leaders, one of which was an Army combat veteran who probably should have had some training in this. The other guy had no training, unfortunately, no medical training. And so they left him there to nap, come back the second half of the day, go about their business, check on the other boys, figure, oh, he's just tired. Maybe he's got a stomach bug or something. And that night or that afternoon, they realize, okay, maybe there's something wrong. He's pretty much not responding to us. We're talking to him, he's talking back, but he seems a little off. So they start to realize maybe we need to get him down. So of course, late in the afternoon, the sun sets real quick up in the mountains. Most of you know that. And so they kind of start to panic and they're like, okay, what should we do? Let's go down as a team. So they pack up, I think it was 8 boys and the 2 leaders, they start going down the mountain, and this kid is getting 100 feet and just falling to his knees. So they get him up, bring him another 100 feet, get him up. And this is grueling. This goes on for several hours, which I can't believe they did that for several hours. That should not happen. But they can't get cell signals, so they got to get this guy down. So finally they realize, okay, this is, he's not making it down this way. So one of the scout leaders was actually happened to be a marathon runner. So he ran about 9 miles as the sun was setting and ran to his car, then had to drive 30 minutes to get cell phone service out of the valley up there near Park City, came back towards Salt Lake, got cell service, got a helicopter out there. And by the time the helicopter arrived, he was completely unconscious, this boy. And unfortunately, they did CPR on him. They did everything they could. They transported him. I don't know if he went to Salt Lake. I can't remember. But he passed away. So his dad is now speaking out. That's a situation that should never have progressed that far. It's easy to talk about in retrospect and criticize, but just think about stuff like that. Know your people, know your patients. If you see someone who's a competitive athlete and they're not acting right, there's probably something more to it, right? It takes a lot for a teenage boy to not want to go on a hike or not want to eat a ton of food at a campfire, right? So something to think about. So AMS and Haste treatment, gold standard, again, descent. And I put this stupid picture here just so that you maybe, if nothing else, remember the picture and you remember the movie Descent. It's a really dumb movie. If you've not seen it, don't bother. But descent, descent, descent. Every WMS guideline is always going to tell you this. Every video on YouTube is going to tell you this. Descent. Don't delay treatment. Don't delay descent for treatment, I should say. And there's another slide on that later. The gold standard of treatment, I mentioned it before, dexamethasone. You should administer dexamethasone immediately if you suspect HASE, okay? If you're confused, you're like, well, they have some neuro symptoms, but it might be HAPE, it might be HASE. How do I really know? Give them the dexamethasone, descend immediately if possible. I don't know if it was on a previous slide or if it's coming up, I can't remember, but HAPE will have neuro symptoms if it progresses long enough, okay? So if you're at a point you don't know, treat it, give dexamethasone, give something and get them down. Most importantly, get them down. You can give supplemental oxygen until their oxygen sats are at 90% or above. You can use a pulse ox. I'm going to talk about that in a minute because that can be problematic. Portable hyperbaric chambers. The clinical guideline says, yes, if you have them and you know how to use it, they're helpful. Certainly at a place like Everest Base Camp, they have this kind of stuff. But if you're just out hiking, in the back bowls of Vail or something and you're cross country skiing, you're not going to have a portable hyperbaric chamber. There's a picture of one there. You can use it for divers. You can use it for climbers, but relatively impractical. If you do have it, according to the clinical guideline, you should use it. One risk with those is that they can explode because they can become overpressurized. So if you're going to use it, know it inside and out, know the technology. Acetaminophen, ibuprofen for headache. This is for treatment, not prevention, right? So acetaminophen, not recommended for prophylaxis and not recommended for prevention. But in a treatment scenario, you can use it to treat headaches. Acetazolamide, there was only one treatment study where they actually looked at acetazolamide for treatment of AMS and HASE in the clinical guide. And it has anecdotal efficacy, but we don't have enough data to really say that it's a good treatment drug. Now, if that's all you have, yeah, the person is symptomatic, I'm probably going to give that, right? And feel free to disagree too, but for me personally, I would give it. But again, if you're looking at the quality of the data here, there's really only one good treatment study that the experts considered for this guideline. Now for HAPE treatment, so that was AMS and HASE, right? HAPE treatment, again, descent, there's the stupid picture again. So descent, descent, descent. The medical gold standard, in this case, again, this is HAPE treatment. If you know it's HAPE, they're not having a lot of those neurological symptoms, but they are symptomatic, you're gonna start descending. And as you're doing that, you can give them nifedipine. Nifedipine 30 milligrams over 12 hours is what they recommend in the clinical guide. And it's a calcium channel blocker, just so you know the mechanism of action. And you definitely want to give nifedipine and those phosphodiesterase inhibitors, which I'll talk about in just a second, if descent is impossible or delayed. So let's say a storm is moving in, it's not safe to descend. You definitely want to give this. Don't wait on this. Okay, so, but obviously descent is your first option. If nifedipine is contraindicated for various reasons, you should know your patient, try to get some history on them. You're going to give some of these phosphodiesterase inhibitors, so sildenafil, Viagra. Not preferred, they're not the first line treatment, but it does talk about them in the clinical rec. You can use them if you have them. Some mountain med people swear by sildenafil, Viagra. So there's anecdotal evidence, but the clinical rec says they're not your first line. You really should have nifedipine if you're doing this kind of work. If both of those classes of drugs are contraindicated, you can give dexamethasone. The clinical rec basically says that for acetazolamide, dexamethasone, there's not enough data. So really you shouldn't be using it when you should have nifedipine. But again, like I said with the last slide, if that's all you have, yeah, I'm going to use that at some point, right? If I can't descend, the person's symptomatic, maybe they're starting to even have neuro symptoms, yeah, I would give that. One of the shortcomings with the data in the clinical guide, and they acknowledge this, is really they've only looked at adult studies, high quality studies that endorse nifedipine. So pediatrics is really a whole different thing, and I won't even broach that topic. I'm not a pediatrician, but just know that this is for adults. Pharmacological prophylaxis only is for patients with a history of HAPE. So this is a caveat with nifedipine. It really is for treatment, but you can give it prophylactically per the guideline if the patient already has a history of HAPE. So again, trying to have a history on people you're climbing with is a good idea. I'm not saying go ask your friends their medical history to go climb Pikes Peak. I'm just saying know as much as you can. And certainly if you're a medical professional and you're working in that capacity, you want to at least ask them if they have a history of this. It's just like having a history of a heat injury or a cold weather injury. That puts them much more at risk for a second injury. So here's kind of a summary. Bottom line, Diamox acetazolamide. Diamox is the brand name. You've probably heard of it. This is going to be great for your prophylactics, your acclimatization. You can use it to treat symptoms. We talked about all the caveats of that. There's the side effects. It is inconsistent for prevention and relief, especially with headaches, which again is one of the main and first symptoms that you'll see with AMS. It's not great. So you want to probably have in your kit also some ibuprofen, okay? And then dexamethasone, we talked about, that's really more for treatment. Has been used for prophylaxis, but really in rare situations like military operations. You can also give supplemental oxygen. I mentioned it before. If you happen to have supplemental oxygen to give, that's great. You should give it. It'll resolve most people's symptoms pretty quickly, but you should never delay descent waiting for oxygen tanks to be delivered or anything like that. If supplemental oxygen, if you have it and it doesn't resolve your symptoms, dexamethasone is going to be your next line treatment per the clinical guideline. So that's a lot of different caveats and things with the drugs. I would definitely encourage you to spend some time digesting it and kind of make your own conclusions about what you would use based on how these different drugs work. But that's kind of the summary from the clinical guides. So key takeaways. I know I'm probably close to my time here. So pulse ox, I'm going to talk about that in just a minute, just because I think it's important. It's not in the clinical rec, but people always say, oh, just slap a pulse ox on them. Well, it's not that simple. Other recommendations, I would always have a dosage chart in my pack just in case I become incapacitated and I have a whole thing full of meds. I want someone else there to be able to look at the chart and at least say, okay, this one is circled in red and it says 125 milligrams and there's the bottle that's 125 milligrams. Put 2 and 2 together, give me the drug. So having a basic chart is great. You should really always have that. And then other emergency things that I just mentioned. Knowing neurological signs and symptoms, this is important. Less important to try to distinguish between HAPE and haste, unless you're really getting technical, but just knowing that if you're starting to see neurological symptoms, you need to stop. You stop that person from ascending further and take an inventory of what's going on. So headache, okay? I grew up in Colorado, went to college, we bring beer, we go up to the mountains, maybe people smoke a cigarette or smoke other substances. A lot of times it's like, oh, well, we drank last night. I got a headache from that. I have a headache because I haven't eaten enough today. I have shortness of breath because it's freezing cold out here. I'm confused because this is not the route I'm familiar with. All of these could be true, but as a medical person, I would say err on the side of, hey, this might be an early indicator of altered mental status, especially headaches, okay? So make that your first differential diagnosis, and then you can, rule out those other things or hopefully rule out AMS. Other elements, I just want to mention, people always underpack in the mountains because you don't want to hump around a ton of weight. But if you look at the data, and it's way outside the scope of this, but if you look at the data, a lot of people who spend significant time in the mountains on hiking, backpacking trips, and I'm talking high mountains, right, where it's hard to breathe already, you don't want to bring a lot of stuff. They almost always come back with gastroenteritis if they've spent more than a week out in the woods. And you might say, oh, that's because probably they're drinking the water. Actually, it's because they're not nourishing their gut flora because they don't want to pack enough. So sometimes a person is just not eating because they don't have food to eat, or because they feel nauseous because they're developing gastroenteritis. Statistically, there's a good chance of that. But again, I would first suspect that a person eating less or not eating and nausea are actually early indications of AMS. And then, hopefully you can rule that out and maybe look into gastroenteritis. I always recommend people bring a little probiotic with them if you're going to be out for an extended period. There's little probiotic pearls, you can buy on Amazon. If you know you're going to be packing light, then you should bring something like that to keep your gut healthy. Sat phone, I mentioned that. Not everyone has a sat phone, I get it, but there's a lot of cases where lives could have been saved when descent was impossible if the person had a way to communicate with emergency medical services. Really quick, want to talk about pulse ox, and then I will shut up. But pulse ox, if you don't know how it works, you should know how it works if you're going to be using it in your practice. I learned this. I used it as an Army medic, never cared how it worked at all, but it's actually pretty interesting. Pulse ox, here's a little graph. Bottom line of this graph is it's showing when you push LED light rays through blood vessels, like in a pulse ox that you put on someone's finger, or by the way, you can put it on their ear or their toe also. Those are the alternate locations. The light reflects differently when it hits oxygenated hemoglobin and when it hits reduced hemoglobin, which has released its oxygen to the tissues. So pulse ox is actually measuring the reflection, I should say, of those waves that are coming in at different frequencies. So I won't read all this, but basically just for you guys to know, device accuracy, and some of these articles actually come from some other WMS docs. Device accuracy, if you're using little pulse ox, which I always recommend you carry, I carry them on planes and in the mountains, it declines significantly when oxygen saturation is below 80%. So you really shouldn't be using them to make a definitive diagnosis. They are a good tool, but just know the limitations of your equipment. Really kind of, I would sum up how to use it with the following paragraph, which this physician who wrote this said that really requires an experienced examiner to diagnose these altitude illnesses, and most especially to use these different sexy tools. It seems great, right? I slap a pulse ox on you, I immediately know that you have low O2 sats and that we need to descend. Well, it's not that simple. What they actually found is that the most accurate time to measure it by far is during sleep and physical exertion. So if you can get the person up and exerting themselves, then you slap a pulse ox on them, that really greatly increases the value of the reading that you're going to get. And this is for early signs of AMS. If the person is already symptomatic, you should know what the other symptoms are. You wouldn't even rely on this. And below 80% O2 sat, it's not reliable anyway. The reason that this is best done when someone is physically exerting themselves is, I kind of gave you the answer I was going to do as like a quiz, but once perfusion is decreased, when you're cold, which all high altitude environments are cold, when you start losing that perfusion in your fingers and your ears, don't forget you can use it on the ears, you get that severe vasoconstriction, blood is being shunted back to your core. And so the pulse ox, that light wave that should be reflecting off the hemoglobin and reduced hemoglobin in your blood vessels, it's not going to work. The physics of it just doesn't work. You guys can look at the physics here. I could nerd out about it, but I won't. There's some terminology there that might be of interest to you, but there's a DC and an AC component to the signal. So essentially they're converting to an electrical signal based on light reflection. And unfortunately, when you have poor perfusion, which you will at that altitude, most likely, you're going to have issues. So if you get the person to do a little bit of physical activity, try to restore perfusion to the extremities for a little bit, then slap the pulse ox on them, you'll likely get a better reading. But again, that shouldn't be the way you're making a diagnosis. You can just use it as an adjunct to confirm your diagnosis. There's a technical note there if you want to know more about it. Really, for these things to really work, you have to calibrate it. I could send you all the data sheets. You got to calibrate these things in a lab where you're measuring the heart rate, you're measuring O2, and you're measuring CO2 on exhalation, and then you're measuring with a wrist pulse ox, and then you're measuring with finger pulse oxes. So that little pulse ox that you get on Amazon, it's not the best. And usually they have a pretty high percentage error. So definitely know what your percentage error is on whatever device you buy. So bottom line, slow ascent, rapid descent. These are all unfortunate folks who have died at Everest. problem when you're hiking by yourself is that once you get disoriented and once you sit down, as they always say in the mountaineering world, sitting is death. So once you sit down, you're done, especially if you've got cerebral edema. So don't let people sit down. Keep them descending as long as you possibly can. Put them on a litter, put them on a tarp, drag them, whatever it takes. Because once you sit down, especially if you're by yourself and you're disoriented, that's pretty much it for you unless someone finds you. Have a plan. This sounds obvious, having an evac plan, but a lot of people don't think about the fact that depending on your altitude, you can't count on a rescue helicopter to come get you. Extreme case with rescue helicopters is about 19,000 feet. I know people in the military who've done more, but I don't recommend you count on it. And usually it's not actually legal to do that because the air is so thin that you can't get lift under the rotor blades of the helicopter. So don't just assume if you're at altitude and you have a sat phone, you're going to call 911 and the helicopter is going to come get you. That's usually not the case. Make sure you have a descent route. I know some highly trained special forces guys who are climbing Pikes Peak, which is a mountain. If you live in Colorado, everyone's climbed it. You can drive up to the top, pretty standard mountain. These guys were combat veterans, highly experienced, and they did not plan their descent route. They got on the wrong route and they had to be rescued by helicopter. It was super embarrassing for all of them. I still give them crap about it. But that just goes to show you, even the experts can mess up if you don't have a plan. You don't do a map recon, which means looking at your routes on the map, trying to look at them up on the mountain if you can visualize the mountain, if you're nearby, and knowing exactly where you're going. Because once you get hypoxic and that confusion sets in, it's a death trap, I'm telling you, at those high altitudes. So care is very situation dependent and patient dependent, as we talked about. So you can't just look at someone and say, well, they're a marathon runner, they're a super athlete, they're a military veteran, so they're going to be fine. Not necessarily true. Just some data for you. About 20%, this is from Merck Medical, 20% of people who ascend to 8,000 feet and 40% at 10,000 feet will develop some form of altitude illness. So you think about the number of people that are going through Vail Ski Resort every year, that's well over 10,000 feet. 40% of them will have some form of altitude illness. Now, for most healthy people, that will resolve. Your EPO in your blood will get pumped up and you'll start producing more red blood cells, oxygenation increases, and after a couple of days, you'll probably feel fine, but you can't always count on that. So, quote to wrap it up, Edmund Hillary, obviously one of the first to climb Everest, and even he said human life is far more important than just getting to the top of the mountain. So there's the WMS link. There's the resources that I used. Exercise Physiology, really swell book, covers a lot of wilderness scenarios. If you've never read it, it's for a textbook, it's pretty cool. So I will leave it at that. I've probably already talked too long. Thank you for the opportunity. I see there's some, oh yeah, so that's a really good point. Oh, thank you, Ben. CPAP is really good. Okay, you guys, I have a CPAP from the VA because they told me I have sleep apnea. So we actually took a CPAP up to altitude. Really didn't work very well. The motor was making crazy noises and I'm not an electronics person, but yeah, it wasn't great. So they are getting small and packable. And I know for some extreme like mountaineers or the people that run the 7 marathons on 7 continents, they will bring a CPAP with them because again, even if you've never had sleep apnea, you have no sleep breathing issues, you're not overweight, any of the risk factors for sleep apnea, obstructive sleep apnea that is, you can still have the Shane-Stokes respirations. So you're getting poor perfusion at night, you wake up the next morning, you already feel crappy, you go to the even higher altitude, and it's just a bad recipe for getting AMS. So yeah, CPAP technology is pretty cool. They're not really fun to wear, but they are really sexy looking, so yeah. Anybody have any questions, comments? Anecdotes, have you used any of this stuff? I would love to hear it. I'll put my email in the chat too if anybody wants to collaborate or whatnot or has med school tips. I'm a first year, so I will take all the tips I can get. So appreciate you guys' attention. This is a super cool group and I'm really happy to be with all you guys here. So I look forward to the next presenter.
All right, great job. Yeah, the guidelines can be pretty dense. They're pretty detailed. I just wanted to take just a second. I'm going to share my screen. Not many people talk about like vision changes at altitude due to like the physical changes of the cornea. And it's just kind of a little pet thing I'm kind of interested in. So I had PRK last August. Most people think of the vision correction surgery, Lasik. That's probably the most common. I went with PRK because I've spoken with quite a few ophthalmologists and people who've been to altitude. PRK is like the safest for those of us who do crazy outdoor stuff. So first I'll start with Lasik. If anybody knows or wants to go into ophthalmology, basically they truly create a flap, like opening up the upper layers of your cornea. They slice it, whether it's a laser or old school was an actual knife. They put the flap aside, they use their laser through that flap because it's a thinner layer of cornea that's left over after the flap's done. Then after finishing the laser correction, they flop over the flap back and they do not reattach it. It just kind of sucks back on due to like the properties of water basically bonding to each other. So it's like surface tension holding it on. And I've heard people saying there's case reports of people just using a weed whacker or mowing their lawns and having little shards of like landscaping material under their flap of their Lasik. And this the flap does not count as thickness of the cornea, even after it, quote, reattaches. So it drastically reduces the thickness of the cornea and it's more susceptible to changing at altitude. PRK is what I have, and it's kind of miserable. They truly create a like 8mm corneal abrasion with a little scraper, but that regrows. So you get almost the entire thickness back after the procedure. So it barely reduces the thickness of your cornea, less likely to deform with altitude. And if anybody's read the book Into Thin Air, people with radial keratotomy, which is, I don't think even done anymore, the highest risk for deformation at altitude. This is what one of the climbers had, and part of the reason he ended up getting horrible frostbite, losing a hand, a forearm, and his nose. So they basically just, these little lines here are incision lines. So they just radial keratotomy, cut around the cornea, and that allows it to deform, and that drastically deforms at altitude. So just a little thing I like to kind of blab about. Part of the reason I had PRK, it's just really interesting to me, and it can be pretty big effect at altitude. Hey, Andrew, I don't know Smile. What's that one? Is it a different one of the vision correction surgeries?
Yes, it's similar to LASIK. It's kind of a newer technique.
Okay.
I understand they just engineered it to have even more minimal intervention with the way they go in.
Interesting. Yeah, that'd be kind of cool. I'd like to look into it more. Anyway, that's just something I'm kind of personally interested in and something people don't talk about much. All right, so moving forward from there, does anybody have any questions for Gabriella? I just kind of chimed in myself. Okay, so Joseph, are you ready to present the optic nerve sheath diameter article?
I am.
All right, go ahead.
Awesome. So I'm going to go ahead and share my screen. All right, can everyone see that? In presentation mode too?
It looks good to me. I can see you and I can see the presentation.
Awesome. All right, so first off, just wanted to compliment Gabriella on a very awesome, informative presentation. I learned so much from that, and I think she teed us all up well for the rest of this journal club. The paper I read and am presenting on is basically looking at optic nerve sheath diameter and acute mountain sickness. It's correlating that measure with the symptoms of AMS and using ultrasound in order to measure that. So kind of the introduction of the paper. Like I said, Gabrielle, in presenting the guidelines, did an awesome job talking about AMS. Basically, it's like hangover symptoms, GI upset, fatigue, dizziness, sleep disruption. And one of the theories that has kind of been posited as a potential issue or a potential etiology for AMS is the tight fit theory, where you basically have hypobaric hypoxia you have elevations in ICP, you have like cerebral vasodilation, and this is causing basically too much brain volume within a limited space, leading to increased intracranial pressure. One tool that's been used in sort of the ICU hospital setting to look at intracranial pressure in the past has been optic nerve sheath diameter. And this is basically using an ultrasound on the eye to look at the optic nerve sheath. The reason this works is it's contiguous with the subarachnoid space, this optic nerve sheath. So you're able to look at alterations in basically like CSF volume and pressure, which is the theory behind this method, which I'll talk a little bit more about. Diameter of about like 5.2 to 5.9 millimeters in the past has been validated as like an indicative measurement for raised ICP. And the authors looking at this study, they hypothesized that increased optic nerve sheath diameter would be associated with rapid ascent to 4,300 meters, as well as symptoms of AMS. And they also wanted to look at O2 administration at altitude as a way to reduce both symptoms and optic nerve sheath diameter. And the place they actually went was Pikes Peak in Colorado. So that was kind of their basis for a quick ascent. All right, so materials and methods. This was a prospective cohort study. They recruited a bunch of people. These were healthy 18 to 70-year-olds. I have the table later. I believe the mean was right around 24 years old. Exclusion criteria, any kind of cardiovascular pulmonary disease, bleeding disorders, anticoagulation, alcohol consumption recently, viral infection, NSAIDs, Tylenol, allergies to sulfa drugs, and sleeping at an altitude of 2133 meters within 30 days of the trial. So first thing they did was they obtained a baseline optic nerve sheath diameter measurement for participants at 4,600 feet, either 2 weeks before or 4 months after the study period. And then basically there's a road to the top of Pikes Peak. They drove subjects to the top over a period of 4 hours. So very rapid ascent profile in this case, going up about 10,000 feet in 4 hours. They measured optic nerve sheath diameter within the first 4 hours of ascent, and then again after 18 to 23 hours. And they also obtained a Lake Louise score for AMS at those time points. They also measured after 30 minutes of O2 administration via nasal cannula, and they titrated this to 90% O2 sats. So basically no set like amount. There's variability in how much O2 they were delivering, but it was to get above 90%. Severe AMS cases were treated with O2 and dexamethasone. Just some like random methodology. They obtained 3 axial images from each eye, which we'll talk about axial, kind of how that's obtained, what it looks like. They measured both in real time, the sheath diameter, and then they had an independent observer do it after the study. They used means of the 3 measures, as well as the right and left eye, and calculated those out. And then they compared among all the groups using repeated measures ANOVA, and then they did a subgroup analysis using t-test. So here's a picture of how you look at the optic nerve sheath with an ultrasound. So you can see the axial. You're kind of looking across and down into the eye via the upper eyelid. I believe in the methodologies, it said you don't put too much pressure on, you hold it to the eyelid, and you can see in B and C what you're looking for. That green to white X is going to be the optic nerve sheath diameter. And that's going to be at the posterior aspect of the eye, or of the field of vision with the ultrasound. We can also see a coronal view they didn't use in this study, but it's another way of looking at it, more of a cross-section of the optic nerve. And again, E and F are going to show the two different measurements. So B is going to be normal, and C is going to be elevated ICP with an increased optic nerve sheath diameter. Same with E and F in the coronal view. E is a normal optic nerve sheath. And then F, oh, I really like that idea. Throw a TEGI over the closed eye, and then less chance of getting gel in their eye. TEGIs solve everything. We were talking about that on our trauma service today. So E is normal, F is elevated ICP. And then I really like anatomical correlations, especially when you're looking at ultrasound. So I thought this was an awesome picture I found from a different study. We've got the cornea up front. You can see the iris. And one thing they use as kind of a quality control within this study is looking at the posterior lens. They had to have that visualized in each of their ultrasound images in order to ensure that they were getting like an accurate view of the optic nerve sheath and not like catching it in cross section and overestimating the diameter, which I thought that was a kind of a good internal validation technique to make sure that there's quality control on the images. You can see the retina at the back of the vitreous humor, and then optic nerve sheath. It sounded like there was some disagreement on this potentially, but the kind of consensus is you measure it 3 millimeters back from the retina. And it's going to be in cross section, like we mentioned. And as promised, here's the Lake Louise Acute Mountain Sickness Score. It's on a scale of, you can have 0 to 12 points. So headache, GI symptoms, fatigue and weakness, dizziness, lightheadedness. And then basically mild cases are going to be like between 3 and 5. Moderate cases are going to be between 6 to 9 points on the scale. And then 10 to 12 are going to be the very severe cases of AMS. So just I'll give you all a second to look through that. And again, it's kind of on a subjective, but then at the higher levels, you start to get incapacitating measures. And one interesting thing that others might be able to talk about, and this is kind of a issue in medicine as a whole, is it sounded like this was not a very like clinically validated score in the past, and it's been used a lot in research studies. So maybe that could be a point of discussion afterwards, is like the utility of like Lake Louise in a clinical like acute mountain setting rather than in a research setting. Didn't read too much on that, but just they mentioned it within the paper, so thought I'd bring it up. All right, so here was the first table of results. They had an N of 57, 29 male patients. So that leaves us with about 28 female patients. 50-50 basically is the breakdown. Age, as we said, the mean was 24, range was between 18 and 70. We can see O2 sats dropped quite a bit upon arrival to the top of Pikes Peak. They were at about 81%. And then after 18 hours, it measured at an average about 85%. And we can see the Lake Louise score, baseline was about 0.4, upon arrival 1.7, and then after 18 hours bumped up to 2.2. Optic nerve sheath diameter between all subjects, they didn't find a significant difference, but it bumped up about 0.02 centimeters. And there is no significant difference within people who were well, both from baseline to the top and also after O2 administration. The couple significant findings they did find in patients with acute mountain sickness, they had a significant increase of 0.03 centimeters in their optic nerve sheath diameter after Ascent, and this was after measurement at 18 hours. And then after 30 minutes of O2 administration, they found a significant decrease in optic nerve sheath diameter. So kind of breaking that down. Figure 2 is looking at basically going up to 4,300 meters. So they found significant difference in those with and without AMS at 4,300 meters. So we can kind of see that with the optic nerve sheath diameter right at about 0.4 in the people without AMS, and then at about 0.43 in those patients with AMS. And then there was also a significant increase from baseline to the top of Pikes Peak in those individuals who had AMS. So it was, at least in this study, significantly associated with going to altitude if you developed acute mountain sickness. The other metric they looked at was basically looking at after 30 minutes of O2 administration. And they did find a significant decrease of, I believe it's, I'm gonna look at the exact number here, it'd be 0.43 to 0.41 decrease in the optic nerve sheath diameter with O2 administration only in patients with acute mountain sickness. They found no significant difference in those patients who did not have AMS at the top of Pikes Peak. And then one other finding that they didn't have a figure with was basically there's no relationship between optic nerve sheath diameter and oxygen saturation, or optic nerve sheath diameter and Lake Louise score, which were a couple of the other metrics they looked at in this study. All right, so the paper's discussion, like we talked about, increase in mean ONSD in subjects with AMS and greater mean ONSD than in subjects without AMS. Basically sums up the findings. O2 decrease mean ONSD in subjects with AMS. And AMS symptoms, O2 SATs, clinical response to O2 and dexamethasone were not clearly linked to ONSD, but kind of flipping back to both of these figures, we can see there's just a ton of variability, even among patients with AMS, without AMS, in the directionality of where their optic nerve sheath diameter went and in the magnitude of the changes. So like I said, there's a lot of variability in this study. It seems like a lot of individual variability, and probably like we talked about, Gabrielle mentioned in hers, just a lot of individual variability in response to altitude. That's tough to account for in studies like this. And another interesting thing, most of the measurements fell below that cutoff of 0.52 centimeters, which in the past has kind of been shown to be the lower limit for elevated intracranial pressure when measured in optic nerve sheath diameter. One kind of strength of the study potentially is the rapid ascent profile might have brought about greater symptoms of acute mountain sickness. A lot of other studies were slower, it looked like. We mentioned the visualizing posterior lens as a standard, and kind of just a general theoretical issue. The relationship between AMS, high altitude cerebral edema, and elevated ICP is still kind of being teased out over the years. Strengths and limitations. Some of the strengths, the high risk ascent profile, like we said, half the sample experienced AMS, so a good amount of people were symptomatic within this study. So there was like good amount of power to pick up any changes, any issues with the optic nerve sheath based on AMS. Larger sample size, especially for a wilderness study. They had good standardization of the protocol. Some limitations, we mentioned 1/3 of the patient population had a decrease in the optic nerve sheath diameter after ascent, which it kind of averaged out to show significant increase in the AMS population. But I think that's not insignificant, that there's a subset of the population that this really isn't working for. It's like a predictive tool of like, you go to altitude, this measurement increases. Then a very small subgroup of Dex, if I remember, I think 7 individuals received dexamethasone within the study. So they weren't really able to pick out an effect of dexamethasone on optic nerve sheath diameter. They had multiple operators running the ultrasounds. And one thing I found really interesting was the inter and intra-observer reliability that's kind of been validated in measuring the optic nerve sheath has been about 0.02 to 0.04 centimeters, which if you guys remember going back to the table, we can flip back. A lot of those significant differences, 0.4 to 0.43 and 0.43 to 0.41 are almost within that, or are actually within that range of error. So even though the study had like adequate power to pick up a significant difference, there remains still the possibility that this was due to or within the realm of error based on like what's been validated in the past with this measurement. One thing I thought was potentially a limitation of the study is they were looking at acute mountain sickness. I think there would probably be greater sensitivity if you had a patient population with high altitude cerebral edema. I think that would be, this tool would potentially be more sensitive in that patient population rather than AMS, since the pathology of that is like part and parcel increased intracranial pressure from cerebral edema. So there are my references. Thank you all for listening. If you have any questions or any points of discussion, would be happy to hear them.
All right.
Hey,
Yeah.
Joseph, oh, go ahead, Doc.
No, go ahead. I'm gonna mute myself. Go ahead.
Oh, okay. I just was going to add a quick comment. Maybe you'll find it interesting about this whole topic. Because this is the one I wanted to present, but you actually did a much better job than I would have done it. So good job. But no, I'm serious. But I actually, I do a lot of stuff with like space medicine, and in space, what they have found is optic sheath issues as well. And intracranial pressure issues, right? So they use the optic sheath to monitor that. But it's interesting because they basically the theory, as I've seen it, and maybe you can tell me if this is, if you agree with this, is that CSF builds up. So even if you don't have ICP, CSF builds up in that sheath, and it's kind of like a one-way valve. So that CSF builds up for whatever reason, but then it can't get out. So it's not, for that reason, in space at least, it's not an accurate gauge of ICP necessarily. So I don't know if you can speak to that, but just thought that was interesting.
No, I find that really interesting. Honestly, you're probably closer to anatomy than I am, so you've got a better handle on that. But I think that's another interesting kind of confounding variable at play here. That at least I didn't get too deep into it, but I mean, like looking at intracranial pressure, a lot of times in the hospital, you're going to be looking at like opening pressure of a lumbar puncture or like more invasive procedures along those lines. So like looking at optic nerve sheath diameter is a less invasive proxy for that, with limitations to be sure.
Yeah, awesome job.
Cool. It'll be interesting to see if maybe different methods or different, I think the techniques are fine. Different methods, different ascent profiles, different populations. It would be kind of interesting to see if this does pan out, or if it was just kind of a cool thing to try and it's not going to be useful for AMS. But yeah, it would probably make sense for Haste, but I think if I was suspicious for Haste, I would just want them down and not really take the time to do that. I would just get them down the mountain. So let's see, any questions regarding the article?
I did have a question for you, actually, if that's
Sure.
all right. Could you comment on the like Lake Louise score, if it's like clinically or like useful in the field, or is it more just like a research tool to be used?
It's definitely a good research score, and I think it's become the standard that everybody uses for research purposes. I think that's more what it's for. I think you're kind of on the right track with that. With diagnosis in the field, it's going to be a lot of history that's going to be the big determinant. You want to get over the patient's past medical history, their medications, their prophylaxis, their ascent profile, and their history of prior AMS will probably be more indicative of whether or not they have AMS than going through that. Because like we've talked about, whether or not they're on Motrin might get rid of the headache aspect, whether they have other health conditions that could change that as well. So I think personally, it's probably more from a research perspective, unless anybody knows differently. But with that being said, so Sarah, are you ready to go over your article?
I can. I need to switch from my phone. I just got back home from clinic, so I'll need to switch from my phone to my computer real quick.
Okay.
But
yeah,
then,
go ahead and
yes.
do
Oh, hi,
that.
Joe.
Hey, Sarah. Good to see you.
Nice to see you too. Let me switch out real quick, and I'll join in, and I'm ready to go.
All right, sounds good.
Thanks.
While she's doing that, Andrew, do you have the cases pulled up? Maybe we could work through one case while she's kind of re-logging in.
Yeah, I can do that real quick.
Awesome. Kind of pepper it in as we go. Although I don't want to keep you guys past 9. That's the typical final endpoint, but gets us something to keep going with. And as an aside, I'm reusing these from last year's session. So if anybody has fantastic memory and remembers this from like 16 months ago, you might remember these.
All right, can everyone see the presentation all right?
Yeah.
Okay, so these are not my slides. My name is not Justin, my name is Andrew. But I will be taking us through some of these cases. So I'll just zoom right through the first one. So our patients, Bill Paxton and Chris O'Donnell, are going to do a quick hike of 8,000 meters to the top of K2. What sort of things are on your mind in terms of preparation that we can do for prophylaxis for all these wonderful diseases we've been talking about this evening? And I won't ask for like live talking, you can just type in a chat to make it smoother. And let's see if I can figure out how to pull up the chat concurrently. Here we go. There we go. Spend several days for acclimation. Yep, that's a good idea. As Gabby mentioned, or Gabriella mentioned in her presentation, slow ascent, fast descent. That's a good one. What's like the classic board drug? Is there something anyone can just type it in there? There you go, acetazolamide. Yep. So remember, when you're in the hypoxic environment, you're going to be giving yourself a respiratory alkalosis with your hyperventilation. So you just want to do a prophylactic metabolic acidosis with acetazolamide. If there are contraindications to acetazolamide, and there really aren't many, the only one is that you have an anaphylactic reaction to acetazolamide or other sulfur drugs. So if they're just like, oh, I get like a rash from sulfa, that's not contraindication. It has to be like true anaphylaxis. Then you can go ahead and take some ibuprofen. As you mentioned, stage ascent or just slow ascent. And there's like some fancy equipment that you can prepare for as well. You'll hear a lot of like sort of urban, or I guess outdoor legendary medications, but so far the evidence hasn't supported any of these that are mentioned here. Okay, so you're like the medical expert on this team. And one morning, Bill is complaining of a moderate headache and some nausea and a little dizziness. He had a few swigs of whiskey last night, but other than that, he's been doing good on his hydration and his nutrition. There's no trauma recently during his climb. So his vitals, heart rate's 102. His respiratory rate is 24. He's starting at 85. His blood pressure looks good. He's alert. He's oriented. His lungs are nice and clear. He's got a normal neuro exam. I know we all know the diagnosis here. So my next question is, what's your plan? What are you going to suggest when they ask you what should we do next? Are you going to like drop everything and take him down the mountain? I see rest and stop ascent. Yeah, I like that plan. Take more acetazolamide. Yep, that's another good idea. So what's up? This guy obviously has acute mountain sickness. And some things we can do, you can slow your ascent and spend some time to acclimate. You can descend a little bit. You can give supplemental oxygen if you've brought it. I guess there's this fancy like portable hyperbaric chamber. If you like Google image the Gamma bag, it looks pretty crazy. It's I wonder if they just like bring that in their pack. But yeah, it's just like a portable hyperbaric treatment. So you give them a steroid, give them more acetazolamide. You can try to treat their symptoms with some more ibuprofen. So I've never seen this movie. I have to like do some sleuthing on like what the movie pop culture references are, but the movie's called what's it called, Maximum Height or something. Yeah, it's horrible. Yeah, I think there's some gifs. I think that's where the gifs are from. So I don't take credit for any of these jokes. Okay, that's the first case. Looks like we did a great job knowing all the recs. Thanks a lot to Gabriella's presentation. Are you ready to move on to the next case, or do you want to switch gears and go on to the other presentation?
No, I think this is, Sarah, as long as it's okay with you, we're not going to keep you over. I think it's kind of nice to change of pace, do some cases, keep interactive, and we'll get back to articles after.
Sorry, so that is yes to changing over to Sarah's presentation?
Sarah, is it okay if we keep going with cases?
Yeah, keep going with cases.
Keep going with cases.
Great.
All right.
Yeah. I'm good. I'm in it for the long haul tonight.
All right. So you're keeping tabs on Chris's situation. They slowed their ascent. They're keeping up with their hydration, but they consult you again. Chris is a little short of breath now, and he's starting to cough, and he feels pretty bad. His vitals, his heart rate's 114. He's respirating at 36. Jeez. And his SpO2 is 62. His blood pressure is still okay. Still alert and oriented, although he looks like he's in respiratory distress. On their pulmonary exam, he's got some crackles. His neuro exam's okay, but he's looking quite short of breath. So what is your plan now? What are you concerned about? Good, that's the diagnosis. So what would the plan be? Yeah, descend ASAP. You want to get this person to where they can provide higher level respiratory care. So here is a GIF of a man descending a mountain. I probably wouldn't recommend this mode of descent unless their shoulder joint is like made out of titanium. But there's like, as we mentioned, there's some other treatments we can do. There's the Gamma bag. We put it on CPAP, but these are like damage control things. They really just need to get to the hospital ASAP. And yeah, I see nifedipine being mentioned. Yeah, you can do your tricks to try to prevent fluid from getting into his lungs. So these are recommended, I believe, if you're like stuck and you really can't descend right away. These are some damage control things you can add on. But yeah, descent is really what he needs, and should have a low threshold to recommend that. Not recommended, interestingly, beta agonists, probably for the pulmonary effects. More acetazolamide is not really going to do much at this rate. Okay, this is the last case. So good job, you saved Chris's life. Everyone's back at the base camp. And I suppose you're in your tent, you start to notice a foul odor. What's on your differential for that? Gangrene, I like that. This is a joke, I believe, that I didn't write, but so it could be like body odor, it could be like this, I don't know, like spoiled food. But apparently there's a lot of like articles on people farting in their tents and that causing problems during these austere climbs. And so I haven't looked over these articles, but maybe I will tonight. Essentially, just people can like get exposure because of not being able to tolerate being in the same tent as other people. I think that's what this slide is for. I'm not sure, but hopefully I delivered that joke okay. This is the end of the presentation, I believe. Yes. All right. Yeah, that's all I've got for you guys tonight. I hope you enjoyed these cases. It's good to kind of frame things in a way. Once you look up the primary literature, it's like there's a lot of information on the counter. So hopefully this helped you organize it a little bit.
Perfect, thanks. Yeah, I've heard Paul Auerbach talk about HAFE. He delivers it very well, and it actually, I don't know, Boyle's law makes sense with it, but I still am not convinced.
Yeah, maybe ease down on the lentils a bit when you're packing grapefruit.
Not deliver hate. No, that's how you don't get invited back. All right, thanks, Andrew. That was it's nice to apply what we learn as we go. Sarah, whenever you feel ready, take it away.
Okay. So I threw together a few slides. Let's see. Yeah. Share screen. Okay. Okay, so, oops, how do I put that away? There we go. Okay, so I read the Radical trial. Let me know if you can't hear me. Can everybody see the screen?
Yes.
Yep, you're good.
Awesome, okay. And so this is reduced acetazolamide dosing in countering altitude illness, a comparison of 62.5 milligrams versus 125 milligrams twice daily, also known as the Radical trial, which makes it way more fun. So the North American guidelines have proposed that 125 milligrams twice daily is the prophylactic dose to prevent acute mountain sickness. And this study, I think it's the first of its kind, trialing a lower dose of acetazolamide. And historically, I've always taken 250 milligrams twice daily when I go from sea level, like to Telluride or something, but it definitely makes things taste awful, and you're in the bathroom all the time and having to field squat all the time. So a lower dose is like a very exciting prospect for me. So this was a prospective, double-blind, randomized, the best kind of study we know, non-inferiority trial of trekkers to Everest Base Camp in Nepal. They originally looked at enrolling people from Alaska as well as Nepal, and then they decided to exclude the Alaska arm due to differences in latitude, altitude, as well as differences in the difficulty of the terrain being climbed and rates of ascent and such. So originally they talked to about 130 people and ended up with 96. And the participants were randomized to receive either 62.5 milligrams of acetazolamide twice daily versus the standard dose of 125 milligrams. And the primary outcome was incidence of AMS, and the secondary outcomes were the severity of AMS using that Lake Louise score we've been talking about. And I'll show you that in another slide, as well as looking at the side effects in each group. So their question that they wanted to answer is reduced acetazolamide dosing inferior to standard dosing in prevention of AMS? And there was a recent published meta-analysis right before this study that concluded that 250 milligrams per day was the minimum effective dose to prevent AMS. And this study sought to add clarity to that conclusion in question. And I think it's an important question because acetozolamide, as we discussed, does come with side effects. They can have paresthesias, frequent urination, altered taste, to a lesser extent, headaches, nausea, rash. And if a lesser dose is not inferior, then that would be best practice. So their participants, they had approval from the DePaul Health Research Council, the U.S. National Park Service Internal Review Board, as well as the University of Utah Internal Review Board to do this randomized double-blinded non-inferiority trial. And they did it in Nepal between March 2012 and March 2016. And they, as we discussed before, they decided to exclude Alaska. And they chose a non-inferiority design because many doses of acetazolamide, including the standard of 125 milligrams twice daily, were shown to be safe and effective in other placebo-controlled trials. And so just doing the non-inferiority design, even though it probably would have been better to have a placebo arm, that allowed them just to compare the true treatment groups directly without the placebo arm. So they recruited people planning to trek to Everest with flyers online and at hotels, as well as a research assistant or co-investigator just approaching people and trying to get them to enroll in this study. And then this is the participant enrollment and flow during different stages of the study from the paper. So the side effect questionnaire included the following questions. In the past 12 hours, have you experienced the following symptoms? Tingling of toes, tingling of fingers, increased urination, taste change of beverages. And that questionnaire was not like officially validated. And the symptoms were self-reported on this 5-point scale from 0 to 5, with 0 being none and 5 being severe, incapacitating. And one thing that I thought about here was the power of suggestion. And then they had them record these in booklets, and they collected them at the end of the trek in Kathmandu. And if that wasn't possible, then the participants mailed the booklet back. And here's that Lake Louise score we were talking about, except I might have an older score because they still, difficulty sleeping is in there. And so it's symptoms of headache, gastrointestinal symptoms, fatigue or weakness, lightheadedness, dizziness, difficulty sleeping. And then they recorded this scale as well. And then regarding the validity of it, the patients were randomized. The randomization was concealed. It was double blinded. And the experimental and control groups had similar prognosis as far as like whether or not they were going to get altitude sickness, and everyone was blinded, and follow-up was complete. And this table is from the study, the incidence of the first mild or severe acute mountain sickness diagnosis in the standard, which is the dark line, and versus the reduced dose, which is the dotted line. And so for primary incidence analysis, it was a non-inferiority design. There were final count was 73 participants with 36 in each group-ish. And they were required to have 80% power in a one-sided test of significance, allowing for a 20% non-inferiority margin. And this was based on the incidence of mild or severe AMS. And then there was an older article that they were referencing that showed that 13.6% of the acetazolamide group, I didn't take very good notes here, I apologize. So I get, I think I have that in a different area. The biggest limitation was the sample size, I think. And I think the data would be much stronger if they had a larger sample size. I feel that the methods were clear and recreatable, but larger sample sizes and the addition of a placebo group would make it stronger. So the average altitude reached in the groups was 5,020, give or take 400 meters in the reduced dose group, and 5515 plus or minus 330 in the standard dose group. Their ascent rate was about 524 meters per day in the reduced dosing group, and 488 meters per day in the standard dosing group. And the time to mountain sickness was a median of 6 days for the reduced dose and 4.5 days for the standard dose. And the overall incidence of mild or severe mountain sickness was 21 of 38 people in the reduced dose group, which was 55%, and 21 of 35 people, or 60%, in the standard dose regimen. And they, in there, I'm not very good with statistics. I always farm that out on papers, but it was statistically significant that there was no harm in giving the reduced dose. And paradoxically, the reduced dose reported a higher incidence of side effects. But this scale shows the mean Lake Louise scores. So early on, the reduced dose maybe had some higher mountain sickness symptoms, and then the higher dose kind of caught up by the end of the week. And then on day 11, they were equivocal, and then they started to diverge again on day 12, but they completed their dose on day 12, or they also would stop taking the medicine if they were about to descend and they've reached their maximum altitude. And so this is just a reference of that meta-analysis where they said that 250 milligrams per day was the lowest effective dose. But given the sample size, I do think that further study with a larger sample size would help clarify this data and add strength to the conclusion and answer it once and for all. And based on this, I think it's reasonable to take a lower dose. And I might consider dropping my altitude regimen from 125 milligrams twice daily to 62.5. So again, limitations of the study, there was variable rate of ascent in the groups. Self-reporting of data is subjective. There's other behaviors that can factor into that. There's the power of suggestion. You know, if I repeatedly ask you if you have a headache, eventually you're probably going to have a headache. The Hawthorne effect, also people tend to act differently when they're being observed or recorded, and the same goes true to self-reported data, as well as I think it would have been valuable actually to have a placebo arm. So notes, in conclusion, 62.5 milligrams was not inferior to 125 milligrams with regards to preventing mountain sickness. They did have a slightly higher incidence than they expected of mountain sickness in people taking acetazolamide compared to other studies where they were comparing acetazolamide to placebo. There was a little bit more here. And again, Hawthorne effect, power of suggestion, all this was self-reported data. I think a better study would also include some biometric data. Patients taking ibuprofen actually had higher Lake Louise scores. So is this some sort of weird interaction we don't know about? Because oftentimes people taking ibuprofen in the literature have had lower mountain sickness, but maybe they were just taking the ibuprofen because they had more symptomatic symptomatic mountain sickness. And there was no reduction in self-reported side effects. So this self-reported side effects, the difference was not statistically significant. So I do think that further study is needed based on this. And this provides a golden opportunity for someone to apply for a Wilderness Medical Society grant and enroll tons of people and recreate this study with broader numbers, a placebo arm, and biometric data in addition to self-reported data. So I apologize, I threw this together last minute, but that was the Radical trial. It's a short paper. I recommend you read it if you didn't already.
Yeah, great job. Any questions on this trial or any questions for Sarah? There is a contradictory article released very shortly thereafter by a opposing Wilderness Medicine Fellowship in medical school, and they have pretty different results. I didn't want to have both discussed because it would be kind of monotonous and repetitive, but it is kind of interesting that there was an additional, it was also a double-blind randomized controlled non-inferiority trial assessing 62.5 BID versus 125 BID, and they got the opposite results. They got that it was not non-inferior.
Okay.
So it was just kind of interesting. Their methods were somewhat similar. Obviously, I mean, they're going to use the Lake Louise score. They're going to go further than that. But this one did have some biometric data. It's just this first article was, it reads better and it's just kind of easier to discuss. But this other article, actually, they're getting ABGs and they're assessing that too. So it's kind of interesting to look over. I'll read a quick snippet from the discussion of this other article. And picture this as somebody typing in a way that is kind of snarky from a research paper side. Let me see here. Okay, our results differ from those of a recent 62.5 milligram investigation, although their statistical assumptions in the setting of minimal observed disease guaranteed non-inferiority results, thus leading to spurious conclusions. So research paper talk, that's kind of, you know, a little bit of rebuttal. So from their view, basically they saw a 10% greater incidence in AMS in those taking 62.5 BID compared to those taking 125. And there were still slightly different, barely any difference in side effects. So now kind of thinking about those articles, and if you wanted to look it up, it's basically just search for acetazolamide dosing for prevention of AMS, and you'll get both articles pulled up. Both are very well-known research organizations, very well-known authors. It's just interesting. They were done almost overlapping times in different areas with different ascent profiles. And then of course, they were both done far before the guidelines. So then that kind of clues you in that in general, the wilderness medicine providers are still recommending 125 BID for prevention. So there's a reason I didn't have both articles discussed. Read very similarly, but it was just kind of interesting that when I read both, I was like, ooh, that's interesting. So I think personally, yeah, if the side effect profile is not that different, maybe there's some slightly improved prevention with the 125. I think I'd probably personally stick with that still. This is a medically rapidly progressive decreased recommended dose, because as she showed back in 2000, they were recommending like 750. And now we're to the point of just 250 a day total. And even when I was a resident, there was a student presenting on altitude illness, and she was talking about how it was 250 BID recommended, and I was just biting my tongue. But 250 BID, just biting my tongue. But it's coming quick, and even back then, I only knew that because the Tintinelli's book, if you read, if you're ER, back then was still saying 250 BID. So things change quickly, and if you're reading a textbook, it's already outdated. So that's something that I'm sure you med students are trying not to think about with your expensive meds, their textbooks. It's already outdated. Anyway, we have like 15 minutes. It's a little tight, but Alex, are you able to give us a super quick rundown through the risk stratification article?
Yeah, sure. So I wasn't sure what the format of these was in terms of PowerPoints.
Whatever you want.
Yeah, I took notes on it and was just going to discuss it, and if we could maybe pull the paper up. Is that something that you could
give me a minute
up there?
Give me a minute. You talk about it and I'll pull it up while you're doing it.
Yeah, sure. So this one, I think that actually we covered a lot of this already from what we were talking about, but I think the goal of this paper overall was just to address some of the gaps that are out there, especially for, it seems like, primary care physicians and taking care of patients who might be looking towards preparing to use altitude medicine or trying to go out on hikes and going up in high altitudes. So they start off an introduction by going into the amount of people that actually go out on high altitude trekking. I said it's tens to hundreds of thousands per year that are involved in this. And many of them are looking towards physicians' guidance for whether or not they should go out, if they're safe to go based on their medical conditions that they may have. And a lot of physicians might have little knowledge because guidelines really are limited. You know, there's asthma and lung conditions that are documented, but there's really not a lot of information outside of that out there. So the focus here was to give physicians advice on how to conduct a preparation eval for high altitude. And the two things that they really looked at were risk stratification and prevention. So looking and seeing what condition the patient had and then how they can look at preventing that. Methods that they used for this was they cross-referenced different PPE. That's what they used to this pre-participation evaluation, and they identified articles that discussed altitude and chronic disease as well as wilderness medicine. And they broke those articles down to look and see what recommendations were out there. So we go through to the altitude physiology section. That's where they really discuss what's going on at higher altitudes, which I think we're all pretty familiar with. But basically, like we discussed about earlier, as altitude increases, the partial pressure of oxygen decreases, not the percentage of oxygen, but the partial pressure, because pressure decreases at higher altitudes. And then that leads to patients and those hiking having to go out and increase their ventilation, increase their respiratory rate to compensate. And over time, elevated bicarb from the kidneys compensates for that, increased sensitivity of the carotid bodies compensates for that, and also increased EPO leads to increased red blood cells, and that can lead to compensation over days, which is why they usually recommend looking at maps and going slowly. But over a shorter periods of time, compensation for that doesn't happen. So that's where the risk comes in of acute mountain sickness or high altitude cerebral edema, or also high altitude pulmonary edema. So from there, they kind of transition into looking at the illness and the injury and epidemiology. And specifically here, they were focusing on the AMS, Haste, and HATE for this paper, but they also wanted to point out that there are other injuries that occur. So when you're thinking about high altitude medicine, you're thinking about oxygenation and things like that. Some other things to take into account as well are pulmonary infections, also looking to look at cold injuries, like possibly patients who come in with hypothermia, MSK injuries, most of which are attributed to falls, and also GI and GU, and also ENT injuries are things that they took into account as well. But mainly the focus of this was specifically on those high altitude mountain sickness, cerebral edema, and then also pulmonary edema. So they go on a little while later in the next portion to discuss, so let's see if we can scroll down here. So we talked about methods and the basic principles of physiology. They talked about the illness and epidemiology, and then they talked about risk assessment for the next part. So in the risk assessment, they were looking at the main risk being hypoxia versus environmental. And they were looking at mitigating this risk of the hypoxia by looking at an ascent map with the physician. So if you could sit down and look at that and say, this is what our plan is, and you can compare that to the guidelines for how fast the hike should occur, you can put them into risk stratification, and you can say whether they're high risk or low risk for having any kind of altitude sickness. And then there's some other tips that they put out there to give patients, like not flying directly to a high altitude like we discussed earlier. And if you are flying somewhere that maybe 3,200 at an altitude of 3,200, maybe you should stay somewhere that's like 2,700 to get adjusted if you're not already at an altitude that's that high. They're also saying that you should compare the maps that the patients have to Wilderness Medicine Society guidelines to determine their risk, which I kind of talked about a little bit earlier. And then some other things to take into account are medical history and prior history with altitude hike treks and altitude illness that the patients might have had. So some medical history to take into account is like COPD, maybe neuromuscular diseases, kyphosis, cystic fibrosis, anemia, things like that, or other things that they discussed. Then in the next section, they go on to break down some of the, I think it's health conditions is the next thing they talked about. Yeah, so they go to break down some health conditions and some risk factors there. So they said many people who come into physicians looking for this might already know that they have a condition. And there's some pretty common conditions, which you can see in table 2. I said that you shouldn't just recommend against a patient going out and tracking these high altitudes just because they have conditions. Rather, you should investigate and further question them. So you should be asking them questions. Specifically, the 2 things that they looked into were heart and lung disease. So they said for lung disease, you should consider monitoring the patients and looking at FiO2 percentages in them. So they were talking about pulse oxes potentially. And then they broke down a few different conditions like asthma. They said typically tends to get better at higher altitudes. So that's something that you might not expect if you didn't really know about that. They did say exercise-induced asthma, though, can be worse because of bronchospasm over 2,500 meters. So you want to be sure that patients with asthma are well controlled and they have access to corticosteroids and also bronchodilators. And they said for general physicians they need to be comfortable. If they're not comfortable treating these patients, they should refer them to PALM. They also mentioned that obstructive sleep apnea is improved, but central sleep apnea is not at higher altitudes. So acetazolamide is recommended for both patients with obstructive and central sleep apnea. And they said that, like the mechanism with the rest of the stuff, it helps increase O2 SAT and increase the hypoxemia or hypoxia index. They should also take their CPAP with them, which we discussed a little bit earlier as well. So that is the conditions with pulmonary. Then they go on to talk about the cardiovascular conditions. So patients with hypertension specifically can see an increase in their blood pressure by about 30 to 40 millimeters of mercury for when they go up to higher altitudes. So patients who are hypertensive should keep that in mind. If they're having symptoms of high blood pressure, they should increase their current meds. There's not really consensus on one medication to take if they're having symptomatic hypertension while hiking. It's usually typically their medication they take now, they take additional dosages of that. And also they said nocturnal oxygen can help decrease hypertension as well at high altitudes. Another thing they mentioned was atherosclerotic heart disease. Said patients, even if they're revascularized, typically do well with that. And they should discuss current symptoms with the patients, because the number one predictor for patients when they go trek high altitudes is whether or not they actually do things at home. Patients have an increased risk of issues if they're sedentary at home, which is pretty straightforward for that. In terms of arrhythmias, at higher altitudes, catecholamines are increased, which puts people at increased risk of arrhythmias, specifically PVCs. But there's really limited studies out there for clinician advice on whether or not patients with arrhythmias should be recommended to go at higher altitudes. Usually you advise patients with poorly controlled or dangerous arrhythmias not to go, which pretty much is common sense. It's nothing really that they're suggesting that you probably wouldn't know already. They said that AFib and atrial tachy, though, should have a rescue medication, so specifically a beta blocker with them when at higher altitudes. Another thing they mentioned was CHF, so congestive heart failure. They said that furosemide should be given to those patients to maybe take that later if they need that, and if they have increasing edema, to increase their dose potentially later too. So in general, I think their guidelines that they summarized later were to ascend slowly and to abide by the WMS guidelines to see what classification that would fall them into based on how fast they trek up the hill. They said that acetazolamide is recommended. We already talked about dosage for that, 125 milligrams, Q12 for prophylaxis, 250 for AMS treatment. They say nifedipine is what you want to use at 30 milligrams Q12 for high altitude pulmonary edema prophylaxis, and then you want to treat that with 30 milligrams. Like we mentioned already before, they want to avoid depressants like benzos and alcohol. And then also pre-exposure to high altitude helps to increase their ability to avoid the altitude sickness as well. So a few nights at higher altitude can help these patients. So just in general, they say to identify the risk, you want to recognize the conditions patients have, and you want to optimize those health conditions before you plan the trip with patients. In general, a lot of it may not necessarily have guidelines, but this seems to be a good basis for how patients should proceed when they're looking to track high altitudes.
All right, cool. Great job.
Thanks.
Yeah, it's kind of similar to the WMS guidelines, slightly different in that it's more about recommendations for patients who I personally think would be quite high risk for some manner of that article. But more and more we're seeing in all outdoor activities are people who we historically would not see outside. Whether you want to think about like culturally, like lifestyle habit wise, body habit, as all sorts of people, and as well as certain medical conditions are more and more out there. So like the article is saying, like your patients are not going to be satisfied by you just saying, no, you shouldn't go. They're going to want some way to, quote, safely do the activities they're thinking of. So that article is just kind of good to keep in your back pocket, whether you're PCP, pediatrician, ER, urgent care, any semblance of like primary care, if you want to call it that. So I personally think that if you're using home oxygen at baseline, that is kind of high risk to go at altitude. But they might want to do it. Any questions on that article? All right. So as I put in the chat just a minute ago, I had it pulled up on my phone while he was talking. So I did not organize this coming event, but I helped basically distribute the info. So one of our faculty here at Virginia Tech Carilion has been to Everest, has tons of contacts with people still working there. One of our residents who is here in Virginia, who is from Nepal, who's worked at base camp, and one of our other residents who's physically currently in Nepal and from Nepal will be joining us, as well as some of their colleagues that will be giving us a tour live of the base camp, as well as the ER there at base camp. And I think one of them is joining in from one of his high altitude clinics that he works at, kind of discussing what it's like to treat these altitude illnesses, probably frostbite, as well as just rural medicine at about its most extreme. So if you are available and interested, I think it should be a great event and should be a great follow-up to this. I've shared it quite extensively already. I'll be putting it on Facebook as well. And feel free to share it with those friends and colleagues you have. It should be recorded. I don't know when it will be available, but yeah, as long as all the speakers are okay with it, I believe it should be recorded and distributed. And I know the WMS already asked me to have a recording of it, so more of an incentive, I suppose, to distribute it. I'm going to stop sharing. Thanks everybody for joining. The next event is April. It's on tick-borne illnesses. If anybody wants to present guidelines or articles, please reach out to me. I'll send that article, I'll send out the guidelines article and reminder in a week or two. And then I'll see you then. Thanks.